broadcast is now starting. All attendees are in listen-only mode.
Well, that was Journey, and that was Steve Perry, the immortal, unbelievable voice of Steve Perry with the old classic rock group Journey, and who in the minds of many people is one of the greatest rock groups in rock and roll history. And guess what? And I agree with that too. Good morning, and this is Dr. Minarsik. Today is January 25th, and it is 9 o'clock in the morning here in the Chicago area in Zion. And another thing about the Chicago area today is this. So if you see me going like this, or I may have to turn on my heater inside the room a couple times, I'll ask you later on if you think that it's bothering you in terms of the sound, because it does make a little sound. But we're going to try to suffer through today and maybe come out with a good attitude. And you know what? I just checked. Actually, it was 1 o'clock, 1 degree about an hour ago. It's probably about 2 degrees now. So we've just doubled our temperature. Okay, how about if we get going? And today we're going to be talking about 3 things: ovaries and diseases of ovaries, pregnancy and diseases of pregnancy, early and late, and placentas. Big discussion on placental diseases too. I almost was sent to jail at one point in my career for 290 years because of placenta, but that's another story. Maybe I'll tell you later. There's the heater that just came on. Does it bother you? Does the heater interfere with my voice? That's what I want to know. Yes or no? Because there is a little sound to the heater, and you're saying no, so I'm very happy about that. So let's close the frozen guy here and open up the PowerPoints and get going. So this corresponds to the old chapter 2 of one of the older editions of Robbins, which is I've upgraded several times, but these are the 4 things we're going to be talking about. Okay, we finished the entire Mullerian tract diseases, uterus, tube, cervix, vagina, blah, blah, blah. And so today we're going to go on the non-Mullerian derived portion of the female reproductive system. And specifically, we're going to start out with talking about ovaries. We'll talk about the classical degenerative diseases of the ovary, which is basically unavoidable. It's called menopause, I guess. I don't think I have too much to say about classical inflammatory diseases of the ovary itself, oophoritis. Quite frankly, it's, in my mind, I've never seen much of it, so I guess I could say it doesn't exist, but it's usually found in conjunction with other inflammatory lesions in that area. We'll talk about the cysts, okay, which are not tumors at all. They're just cysts. And then we'll talk about the tumors of the ovary, both the surface epithelium, they're also called germinal epithelium, which is a misnomer. It's basically just a mesothelial lined covering to the ovary. Then we'll talk about the germ cell tumors, astoundingly similar to the germ cell tumors of the male reproductive system. Then the sex cord stromal tumors, also analogous to the sex cord stromal tumors of the male reproductive system. And there is a funny little metastatic lesion which is peculiar. I guess anything can metastasize to the ovary, but there's a certain tumor called a Krukenberg tumor, which you'll probably never see and maybe even never hear of. That's always mentioned when we talk about metastatic disease to the ovary. Then we're going to talk about diseases of pregnancy. And the 2 primary concerns, the 2 primary diseases or disorders are tubal pregnancies and spontaneous abortion for early pregnancy. And of course, then in late pregnancy, most of the disorders, diseases, problems are centered around the placenta, okay? Even things like preeclampsia and eclampsia, they're generally related to placental ischemia. So we'll talk about that. And then we'll specifically talk about diseases of placenta itself. The common anomalies, the funny things, the benign tumors, which are called moles, and the malignant tumors, which are malignant proliferations of the trophoblast, which is called choriocarcinoma. I almost feel tempted to tell you my story now, but we just got going and I want to get into the material. But I really did almost go to jail. And I'm sorry, if I said 290 years, I was wrong. It was 480 years. I was threatened by my government to go to jail because I issued placenta reports after the baby went home. How do you like that? God bless the United States of America. Here is the embryologic origin of what we'll be talking about first, the so-called ovary, okay? Now, if you remember, we talked about the entire Mullerian system, but the ovaries themselves are not part of it. The ovaries, at first, the ovarian germ cells appear in the yolk sac of the female embryo. At some point in time, there is a genital ridge, which we see along here, which migrates towards the mesonephros, okay, and eventually becomes ovarian cells, okay? So it's completely independent from what we think of as Mullerian derived. And of course, the ovary itself, if you want to think simplistically, you could think of it as two things. Number one, follicles, and number two, stroma. And of course, the stroma is the connective tissue, and that's in the medulla of the ovary. And of course, in the cortex of the ovary are the various developing follicles, both pre-ovulatory as well as post-ovulatory. And if you remember, we talked about the pre-ovulatory phase of the endometrium being primarily under the influence of estrogen, with some progesterone as well, called the proliferative phase, because the estrogen proliferates the endometrial cells, and then the secretory phase, in which the endometrium secretes material, was post-ovulatory, also under the influence of primarily progesterone from this corpus luteum over here, okay, but also estrogen as well. So if you are in the erroneous way of thinking and you think that estrogen is pre-ovulation and progesterone is post-ovulation, it's not really true. Both of them are in both phases. It's just a predominance of one over the other. Here's a nice little anatomical diagram. You might remember we delineated and talked about the uterus, the tubes, the fimbriated end of the tubes. Of course, right here at the fornix, okay, we then ended the end of our Mullerian tube and went into something that evaginates from the ectoderm, okay? So anterior to the uterus is the bladder, posterior to the uterus is the rectum, and the ovary, okay, at the end of the ovarian ligament, okay, not the broad ligament, the ovarian ligament is the location. Now remember two things. The ovaries are always posterior to the fallopian tubes. That's important because when you examine it from any point of view, in pathology, radiologically, laparoscopy, okay, you have to remember that. Another thing you should remember is that the uterus is both anterior flexed, in other words, it bends a little bit towards the bladder, as well as being antiverted. In other words, the whole organ itself is angled towards more towards anteriorly the bladder than the rectum. So that's our regional anatomy, and now let's look at what you might see at autopsy. A thing to remember is that when you look into the pelvis from the abdomen, from any point of view, everything that you could identify visually with your eyes, which could be seen or felt, okay, is lined by mesothelial cells. Why? Because it's an extension of the mesothelium of the abdomen, okay? And of course, the actual covering of the organs that you see is the visceral mesothelium, or visceral peritoneum, so to speak, and the parietal is along the body wall. So there's an ovary, once again, remember, posterior to the fallopian tube. There's the uterus, there's the rectum, and everything that you see here is your surface mesothelium. In the ovary, the surface mesothelium, being intraperitoneal technically, is also called germinal epithelium, perhaps as a misnomer, but it is those cells which are derived, which ultimately, give rise to the follicles. Okay, and that's why they're called germinal. Here's another nice real picture of an ovary. And once again, this little squiggly, stringy thing here, which you could see some little openings, is your fallopian tube. But the ovary itself has follicles in the cortex and mostly blood vessels and connective tissue in the medulla. Sometimes when you examine it from any point of view, you don't really get that understanding or feeling, but that's the way it generally is. And here's a bunch of follicles that are occurring at different stages. Here's some primordial germ cells, oocytes, so to speak. Eventually, they get surrounded by cells. When there's enough cells to make a space, that's called an antrum, and that's called a Graafian or antral follicle or secondary follicle. But before it gets to that stage, like perhaps here and maybe here, it's called a primary follicle. And there's also something called a primordial follicle, which we're going to talk about. So I guess you could say this is a more or less a linear maturation or cascade of structures which ultimately become ovum and ultimately become corpus luteum, corpus albicans, so to speak. The germinal epithelium, once again, we said was actually mesothelial derived. And that basically gives rise or surrounds the ovum, okay, as a primordial follicle. At some point in time, it gets additional coverings with granulosa or estrogen or pre-estrogen secreting cells called primordial follicles, then maturing more to become a primary follicle. Then when the follicle gets big enough to have a space of liquid called liquor folliculi, it's then called a secondary follicle or an antral follicle. In some of the books, I've even heard the term tertiary follicle, but that kind of confuses me. The granulosa cells surrounding the ovum secrete primarily estrogen, but after the ovulation occurs, the primary cells are progesterone producing, called from the corpus luteum. So the corpus luteum is the luteal phase of the follicle, and the estrogenic or primary phase is before ovulation. At some point in time, this might have been put a little bit out of place, but anywhere along this progression, you could have a degeneration of a follicle, and the ovum is surrounded by a hyaline type membrane called a zona pellucida, because pellucid means clear. And that's a follicle that basically has degenerated, and it's not going to progress any further than that. And this usually occurs during the pre-ovulatory phase. When the corpus luteum then degenerates, it goes from yellow to white. The yellow are the cells secreting progesterone, but then as that goes further, it becomes more fibrotic, and as you know, albic means white, albicans means white, because of the presence of increased fibrous tissue. And of course, we're ignoring all the connective tissue between these follicles, and that's generally called stroma, okay? So can you have stromal tumors as well as follicular tumors? Of course. Here's the very beginning, an oocyte with a very thin amount of flattened, they call it squamous type covering, to become a primordial follicle, okay? When this flat epithelium derived from the surface or germinal epithelium becomes more cuboidal, In other words, it's no longer flat, it's more rectangular. Then it can deserve the name primordial follicle. When the primary follicle becomes completely covered by cuboidal cells, you could then call it a primary follicle. And you still have your unfertilized ovum or oocyte within the middle. And that's probably the very earliest stage of follicular development. At some point in time, this ovum gets surrounded by cells which ultimately will be secreting the estrogen. If the follicle degenerates, it develops this little clear zone on here, and it's called a atretic follicle. And this little clear zone is called a zona pellucida, because this little red hyalinized structure is very clear or lucid. Okay, as this progresses, these heaps of cells around the oocyte become so large that they actually develop a space, and that's called an antrum. So now we are in the secondary follicle, also called a Graafian follicle, also called an antral follicle. And of course, the antrum is the open space which contains nutrients and fluid and hormones and enzymes and everything that will support the cells that are supporting the all-important ovum. Okay, and here we are having an antrum that is so big it is the majority of the follicle itself, and you still have cells heaping upon this ovum called a cumulus oophorus. Okay, the corona radiata is the group of cells, sort of palisaded, which surround it, which are these cells here. And of course, what do we have left? Well, the antrum now contains this so-called important nutrient type liquid called liquor folliculi, which is very appropriate because it is the liquor or the fluid of the follicle. And of course, it's a Graafian secondary, or you might even want to call it tertiary follicle at this point. So here we go. Here's a close-up view. Here's the antrum. Here are the granulosa cells, basically B and C. Somewhere between C and D, the cells look pretty similar, but now we are going from the granulosa cell layer to what they call the theca interna layer. The theca internal layer, which is D, also secretes estrogen. Okay, but the theca externa looks like it's fibrous. So you could say that the theca externa is now part of the stroma. So tumors of the theca externa are fibrous and often called fibromas as well. But let's not digress. Why is this yellow? It's because it's the corpus luteum, and luteum is the word for yellow, okay? When you cut through an ovary that has a corpus luteum, you will not mistake this as being yellow, no matter how colorblind you are. It's probably the most yellow thing in the human body, except for maybe the adrenal cortex. Here are the cells that make it yellow because the cells are rich in cholesterol or fat, okay? And now we are actively producing hormones, primarily progesterone under the influence of LH, luteinizing hormone from the pituitary, but also there's an estrogen effect as well. There's the same thing now. It's also very, very hemorrhagic, especially in the middle. And this is a really, really beautiful corpus luteum. And the rest of this stuff here is mostly ovarian stroma. And what is yellow, if you remember, grossly, is usually whitish microscopically because the cholesterol basically washes out and produces extremely tiny vacuoles, okay? Here is the corpus luteum after it's done its job. It's now gone from luteum, or yellow, to alba, or white, okay? Because there's an increased number of fibroblasts within it, and as you know, white is scar, is fibrous tissue, collagen, fibroblasts. And basically the guy has done a good job, so now he's allowed to just chill out and do nothing for the rest of his life except become more and more white or more and more fibrotic. Okay? So much for the basic ovarian histology and physiology. Let's just kind of summarize now the role of a couple of important hormones we talked about. Estrogen, primarily from granulosa cells, as well as theca interna, is under the control primarily of FSH, but also LH. Okay, you should never, ever, ever think of these hormones of the anterior pituitary as being different. Okay, primarily they have a effect on proliferating and developing and differentiating breast lobules, but also endometrial glands. So the more of an estrogen effect on endometrium, the more the endometrial glands are going to be proliferating. What does that mean? It means dividing, okay? Not necessarily secreting, but dividing. So would you think that a tumor of the ovary that produces a massive amount of estrogen, like a granulosa cell tumor, might result in proliferation, hyperplastic, or even neoplastic endometrium? Of course. Okay, estrogens are also generally regarded as cardioprotective, which classically has always been the reason why women get heart attacks later than men in general. But once women reach menopause, their likelihood of coronary thrombosis, heart attack, so to speak, is about the same as a man. Also, estrogens are regarded as bone mass protective. And that's the reason why women, postmenopausal women, are extremely at risk for osteoporosis, because now they no longer have that bone mass protection. And what is osteoporosis? Well, it's loss of bone mass, isn't it? Okay, so what about progesterone now? Controlled by the same two hormones from the pituitary as estrogen, FSH and LH, but you would think luteinizing would be maybe the predominant one, because lutein means yellow and the corpus luteum is yellow, and that's why it makes all that progesterone. And on the endometrium, the effect is not to multiply or proliferate the cells, but it is for the endometrium cells, at first small vacuoles, which are at the base of the cell, going to the apex, then becoming larger, then actually discharging secretion into the gland, is primarily under the control of progesterone as well. Now, progesterone has kind of the unique and primary responsibility for implantation of the fertilized ovum blastocyst into the endometrium as well. Okay, and progesterone, even though if you look at all of the hormones that are involved in lactation, okay, and there's at least a half a dozen I could think of, even on a bad day, it's the primary hormone for lactation is progesterone. Okay, let's talk about diseases now. Let's talk about cysts, okay? We kind of ignored a primary inflammatory disease of the ovary, and I bet you if I had you against the wall right now and asked you, give me the differential diagnosis of all the primary inflammatory diseases of the ovary, you'd probably say, duh, I can't even think of one. Well, guess what? I could barely think of any also. So, if you want to think of cysts, you know, the ovary normally has cysts, and they're called follicles, okay? So the two major types of primary ovarian cysts are follicular cysts, okay, in the follicular phase of the cycle, the proliferative phase, and then the luteal cysts, which are cysts of the corpus luteum, okay? These are the primary cysts of the ovary itself. There's a whole big differential diagnosis of para-ovarian cysts, but these are the two major groups of primary benign cystic lesions of the ovary. And I shouldn't have even said benign, because a cyst by definition is not only benign, but they're not even really true neoplasms as well. Here's some ovarian cysts in the follicular phase, follicular cysts. Okay, some of the largest cysts known to man, or woman, we'll say, big as basketballs. Okay, we're talking maybe even 50, 60 pounds are these follicular cysts. Here's probably one of the world records down here. A premenopausal woman presenting with a massively large ovarian cyst is probably going to be a follicular cyst. They by far are the most common. Why is this one black? Because it probably has some secondary hemorrhage in it. Here's another nice one. And look how this, I think this is a fallopian tube, is adherent to it. And here's a cyst closer up. Now, I think I could convince you that these are probably follicular cysts simply because it looks very similar to the follicles that we saw in the previous histology. These almost look like they are part of the granulosa cells. Here's the gigantic antrum. Now, this antrum technically could be, 2 feet in diameter, but most of them are not that big. So the primary benign cyst, most common by far of the ovary, especially in premenopausal women, is the follicular cyst. Oh my God, what is this yellow thing? Yellow, the word yellow is luteum, isn't it? So here is a cyst that is very yellow. So you'd think it has to be a corpus luteum cyst, and it is. And these are probably second most common primary cysts, and these are cysts from follicles that are in the luteal phase or post-ovulatory phase. And they can get pretty big, but not usually as big as the follicular cysts. These are in the range of a few centimeters usually. Here it is microscopically. So what's yellow on gross examination, if you zoom this up, I don't know if we can, but if you zoom it up, you'll see these cells also are kind of foamy. And of course that foaminess is due to clear spaces, due to the fact that any steroid producing endocrine organ is probably going to have cholesterol as a storage before it makes its steroid hormone. Okay. Let's get into a real disease. Not that the others weren't real, but something that most people don't believe is that polycystic ovarian disease, classically called Stein-Leventhal syndrome, is amazingly common. Here we got one of the primary sources I had said 5% prevalence. I've seen it as high as 7, 8, and one of the things. So in other words, it's very, very, very common. A woman who is born with polycystic ovarian disease or Stein-Leventhal syndrome, she will never ovulate, and therefore she'll be infertile. She will have very, very little by way of menses, okay? And classically, these women are obese, and they have some masculinizing type features like hirsutism. So if you get a question, I know you're all interested in step questions. So if you get a step question with a woman with polycystic ovarian disease, I guarantee you it's going to say an obese hirsute woman walks into the office and complains that she can't have babies. Well, already you're thinking Stein-Leventhal. Okay, slam dunk. The polycysts are not really that large. They're only a little bit larger than follicular cysts, and the ovaries themselves are only a little bit larger than normal ovaries. But look at all of these cortical cysts here, microscopically and grossly. And here it is on the surface. If you palpated this ovary, it would seem like a little bumpy, and all those bumps are the edges of cysts. And here's one in which the cysts are even more prominent. So this is classical Stein-Leventhal disease, okay? Also, I noticed that also somebody likes to call it PCOD as a nice little acronym for polycystic ovarian disease. This is what you might expect to see in a woman with PCOD or Stein-Leventhal. Now let's talk about the real tumors now, the real neoplasms. Most of the real neoplasms of the ovary arise, once again, from cells which ultimately come from that surface epithelium or surface mesothelium, you remember, which covers the ovary. The majority of them do. Okay, these cells can differentiate into being secreting a watery type substance, and they are usually cystic, but they can be solid, or a mucinous type substance, or they could look as a more rare differentiation, very much like ovarian or endometrioid or endometrial type glands. Okay, they can have both a glandular as well as a stromal or malignant stromal counterpart, which would be called adenosarcoma appropriately. That means we have both a adenocarcinoma feature as well as sarcoma features, or the sarcoma feature could be multiphasic. In other words, it could look like muscle, it could look like blood vessels, it could look like fibroblasts, it could look like bone, okay? The epithelial cells, whether they're benign or malignant or cystic, can look very much clear, like we saw with renal cell carcinoma. Or they can look like transitional, in other words, stratified but not keratinized. And if you looked at it, you would say, hey, these look like transitional cells. Well, that's why we have a transitional cell ovarian tumor, but they look amazingly like a Brenner tumor. And quite frankly, I have a hard time telling the difference. I guess they are different. You know, originally we thought that the cells of the Brenner tumor were germ cells, but they're not. And they're actually cells, epithelial cells that stratify, looking very much like the transitional. Nevertheless, I have to tell you there's two different types. Of course, you could have tumors of the actual germ cells. And we went through the whole list of male germ cell tumors. Amazingly, on the ovary, they are very, very similar, okay? And they can look identical. Of course, the ovary also has stroma, okay, medullary stroma, thecal cells, and they could form like connective tissue, like tumors as well. And finally, the ovary itself is not a magnet for metastatic disease. It's actually pretty rare to get a ovary that has a primary metastasis. Usually by the time they go to the ovaries, they're everywhere else. However, there are tumors that of the GI tract that can metastasize even early to the ovary, and those are called Krukenberg tumors. And I didn't put it down here, but maybe next year I will. So, but let's tell you something else. All of these surface epithelium derived tumors, they can be benign, they could be malignant, or they could be in between or borderline, okay? So could you have something that's serous, mucinous, or endometrioid, cystic or solid, benign or malignant? Yes, but also borderline. And I can remember when I would examine a lot of ovaries, and sometimes I would say, gee, I would like to call this benign, but there's a couple of areas I'm worried about. Well, very often we send them out to the world experts, and they often agree with you, and they'll say borderline, okay? So there we go. This is the general classification of ovarian tumors. And we're going to show you the most common ones. How about if we generally say ovarian tumors, once again, they could be solid or cystic. They could be functional or non-functional. And if they're functional, they're secreting hormones, aren't they? Primarily estrogen. So a tumor of the ovary that secretes estrogen or is functional could probably maybe be called a granulosa cell tumor, because that's where the primary source of estrogen is for the ovary, isn't it? They could be benign or malignant. And I should also add, they could be legitimately borderline. It's not wrong to say, I don't know. The patient wants to know for sure, the surgeon wants to know for sure, but there is a legitimate borderline category, which means it's not malignant, but you better keep an eye on it, okay? Or in most cases, they'll probably take it out anyway, okay? Sometimes, especially with the malignant ovarian tumors, the first clinical presentation may be ascites. So if you were to ask where is usually the first place that a malignant tumor of the ovary might spread to, and that's the peritoneal fluid. In fact, let's give you a general rule. A malignant ascites in a woman is ovarian cancer until proven otherwise. Sure, can pancreas, can colon cause a malignant ascites? Yes, it can. But statistically speaking, a malignant ascites in a woman is ovarian cancer until proven otherwise. These cells, okay, make some of the ovarian, glycoproteins and CA125. There's several of them, but the primary one or tumor marker is CA125. So this will not only be on the surface of the cells if you do immunohistochemistry, but it will also be elevated in the patient's blood. So a woman who has been treated for ovarian cancer and she seems fine, if her CA125 all of a sudden comes up, that's, very, very worrisome, isn't it? Okay, you can see this is cystic because it looks like a cyst here and here. You can see here's the lumen of the cyst, and here's the epithelium. Okay, it looks like it's columnar, and it looks like it doesn't have that big white mucus type of feature. Looks like it might be secreting a watery type substance. So you already know, you could probably call this a serous cystoma, maybe a benign serous cystoma because the cells look very, very orderly. Or you could, if there was a considerable glandular component, which there inevitably are, you call it a benign serous cystadenoma. Now, if these cells were making mucin, you could probably say exactly the same thing, only rather than serous, you might say mucinous, like you see over here. Do you see the difference between a mucinous type epithelium and a serous type epithelium? Yeah, this one's making mucin. You could even see it out here. I think you might call this a benign mucinous cystic tumor, or technically, if you looked at the pathology report, it might say something like benign mucinous cystoma or benign mucinous cystadenoma. Okay. Now, what other thing can those epithelium structures do? Sure, they can form cysts, but they can also proliferate or grow like a finger-like or tree-like or bush-like pattern into these little papillae. Okay, so you could say this is a serous papillary tumor. And of course, if you examine it more, you might decide whether it's benign or malignant, but that's not the purpose here, okay? Quite frankly, from this power, I don't know myself, but I am a little bit worried about it. Here it is closer up. It looks pretty orderly. Looks like there's a whole bunch of these little papillary structures, which are defined as connective tissue on the inside of the papilla and a nice orderly array of epithelial cells. It's serous because it doesn't have that white mucinous thing. So I'd probably call this a papillary serous tumor, benign papillary serous cystadenoma. Okay, well this one I think may have been called malignant, okay? But the thing I want to point out is that it's not mucinous, and I think you'll agree that these epithelial structures are not nice and orderly, but they look like they're basically growing haphazardly and impinging into one another. So that would be a strong evidence for malignancy. If you weren't sure, you might call it borderline, would you? But I would think this is a little more than borderline. Now, in any tumor, not just ovary, but just about any tumor that is glandular and papillary, you may see these little dried up, calcified-like bodies. They're called psammoma bodies. And if you see a papillary tumor of the ovary, whether it's benign or malignant, and it's very papillary, you may also see psammoma bodies. But you remember we saw our psammoma bodies in thyroid tumors, which we'll see psammoma bodies even in brain tumors. So technically a psammoma body is a degenerated, calcified papillary structure. Okay? Here is a nice serous type epithelium. Here is a nice mucinous type epithelium. I'm thinking this is benign and this is benign. But let me ask you this. I don't know, you probably might want to take a guess at it into the question box there. Let's say I told you that you can have a serous adenocarcinoma or a mucinous adenocarcinoma. And you would probably say, well, if they're classified different, there must be a difference in prognosis or biologic behavior or propensity to become malignant or infiltrate or metastasize. Generally speaking, in general, I probably shouldn't say this, but I might say it anyway. There is really not much of a difference between a malignant mucinous neoplasm, which this isn't, and a malignant serous neoplasm, which this isn't. Oh, I think if you probably did a study, you might say, well, the mucinous were a little bit worse. But overall, I think that's not really going to be very helpful because they're basically treated the same way anyway, even though some pathologists might say, oh, well, we saw that the mucinous behaved a little more aggressively overall. Okay. We also said that you could have epithelial or surface epithelium derived ovarian tumors that are called endometrioid. They could be malignant, they could be benign, or they could be borderline. But they don't look serous and they don't look mucinous. And if you've looked at a lot of endometrial glands, they might look like it very similarly, with the endometrium appearing a certain way, perhaps having some stroma. You can have tumors of the ovary, which are also epithelial derived, and they're called clear cell, and they could be benign or malignant. Most of them are malignant, okay, and they can look very, very clear, like the renal cell carcinomas that we saw. Why are they clear? Because they probably have a lot of glycogen and or fat in the epithelial cells. That's why they look clear. You can have a tumor called a cystadenophybroma. Well, from the cystadeno part, you would think it was benign, and from the fibroma part, you would think it was benign. And they mostly are benign, but they have both glandular as well as connective tissue components. Just like a fibroadenoma of the breast, which we're going to get to in the next webinar probably. We said that the Brenner tumor looks like it has transitional cell nests, but there are also transitional cell tumors. The Brenner tumors are largely benign. I think I've seen one or two malignant ones, but they're mostly benign, okay? And of course, you could have some type of carcinoma, primary malignant epithelial tumor, but also having a sarcoma-like appearance, in which case you'd call it a carcinosarcoma. Now, if in this sarcoma phase of malignancy, along with the epithelial malignancy phase, you see more than one type of fibrous tissue malignancy, like fibrous tissue, like bone, like cartilage, then you would call it mixed Mullerian. And don't ask me why it has the name Mullerian, because, like we said, ovary itself is not Mullerian described. So carcinoma with sarcoma would very appropriately be called adenosarcoma. Okay, I'm going to take a deep breath, and then we're going to cover the germ cell tumors, and then we're going to take our break. I think we said a lot about most of the primary malignancies and cysts and histology and physiology of the ovary. But now we're going to talk about the cells, the tumors of the germ cells themselves, which of course for the woman is the ovum, okay? Remember when we talked about testicular tumors, we said most teratomas are malignant in the male? Well, in the ovary, they're overwhelmingly usually benign. And they're usually cystic as well. Okay? That's why, and the teratoma portion very frequently has hair and sebaceous glands as the most common type of component. So that's why they're also called dermoid cysts. They're generally not called dermoid cysts too much anymore. They're called benign cystic teratomas or cystic teratoma grade 1. So especially in the younger woman, the teratoma known as a benign or mature cystic teratoma is without a doubt the most common tumor. Now, if you see teratomas which do not differentiate very much, and they look a lot like primitive cells or immature cells, and they're not differentiating where you can't say this is hair or this is sebaceous gland. If they're immature, then they're most likely to be malignant. So when you look at a teratoma anywhere, the major feature of whether it's benign or malignant is the maturity of the cells. Immature teratomas are malignant. Mature, well-delineated, well-defined, well-differentiated cells like thyroid and brain and hair and all that are benign. Another germ cell tumor of the ovary, not terribly uncommon, is called a dysgerminoma. And if you think that's a big word and you're wondering what the hell does that mean, well, do you remember when we were looking at the testicle the other day, if you were here, and we saw a thing called a seminoma, which is primarily a tumor of pure germ cell sheets. You know, they all look like secondary spermatocytes, okay? Well, dysgerminomas, like seminomas, are all regarded as malignant. They may have a lot of lymphocytes within the tumor, which means the body's trying to fight it, right? With the lymphocytes attacking it or trying to. But generally speaking, they're all malignant. If you remember in the male, we talked about the yolk sac tumors, also called endodermal sinus tumors. Well, guess what? They look exactly the same in the female ovary as well. And finally, here's the most funny, I shouldn't say funny, but here's the most interesting one of all. Choriocarcinomas, or tumors of placental trophoblast, are malignant germ cell tumors. Okay? They look exactly like the testicular choriocarcinomas as well. Isn't that funny? We talked about a choriocarcinoma of the ovary. We talked about a choriocarcinoma of the testicle. Well, we have choriocarcinoma of the placenta as well. And I got news for you. If I showed a choriocarcinoma of the testicle, ovary, and placenta to my smartest pathology buddy, he probably couldn't tell the difference unless, of course, he saw normal tissue along with it. Most common tumor of young females, mature cystic benign teratoma. You see this stuff over here? That's hair. You see all this yucky yellow stuff? That's sebaceous material. Here's some more hair over here. You could even see strands. That's why they're generally referred to as dermoid cysts as well. Okay, number one tumor. And of course, they could be cystic or even kind of solid. This one is probably mostly cystic, and that's why it's called usually a dermoid cyst, even if it's pretty solid. Here's a picture, microscopic picture through one. Does this look like skin? Do these look like an abundance of sebaceous gland? Does that look like a hair? Does that look like a hair that's been cut? Here's a collection of lymphocytes. So that's why they're called generally dermoid cysts. But could they have other features? Could they have thyroid? Could they have smooth muscle? Could they have respiratory epithelium? Could they have retina. Yeah, they could, because the teratoma, of course, are derived from totipotential cells, and they could differentiate to look like anything. But hair and sebaceous material in a woman's dermoid cyst or teratoma is by far the most overwhelmingly common and abundant thing. Here's a teratoma, and I'm going to show you a picture of it. But you would say, oh my God, grossly, it looks like it's just kind of a lobulated piece of fat. And microscopically, this teratoma, if you look at it, and we're only looking at one field, but these cells do not look like they're differentiating much into anything. Now, if you say, well, does that look like it's epithelium? Well, I got news for you. It's not epithelium. This is actually retinal precursor tissue. But the fact is, it does not mature. This teratoma does not mature into recognize epithelial or stromal structures, and that's why the immature teratomas are regarded as malignant. Here's a dysgerminoma. Remember, we said a dysgerminoma of the ovary looks exactly like a seminoma of the man, of the testis. And if you look at these cells, you can say, well, they're not very differentiated, but they look exactly like that seminoma that we saw last week, okay? So pretty much, I think somebody actually debated this with me once, but overall, you know, unless you're a real nitpicker, you could say the dysgerminoma to the female is analogous to the seminoma in the male. Not only analogous, but they look exactly the same. Remember the so-called endodermal sinus tumor? Maybe you don't, that we saw in the testicle, in which you have a particular structure, often called a Schiller-Duval body, in which you have a prominent blood vessel, and then there's a space of clear sort of cells, and then you have kind of a little surrounding of less clear epithelial-like looking cells. Well, this is a characteristic, or this is one of the diagnostic features of an endodermal sinus tumor, also called a yolk sac tumor, okay? So sometimes when I show these germ cells of the ovary, I go, oh my God, am I talking about testicle? And finally, you could see that these are big, pleomorphic, and often hyperchromatic cells. They're in a little cluster. They look like they're invasive. And what if, in all honesty, you said, well, I don't know what this is, but let's say that this patient's HCG was sky high. That means maybe she has a tumor, a large tumor, of the cells that normally produce HCG, like trophoblast. So just because you see trophoblast in an ovarian tumor, that does not mean it's malignant. But if it's invasive, that is the feature. And this is a choriocarcinoma. It's the same exact picture I showed you from the testicle. And I think when we get to placenta, it'll probably be the same exact picture. Here it is. Let's see, do I have another picture of it? I don't know. Let's see. No, we don't. But now that we have gone through all of the common tumors, you might remember that the cortex of the ovary also has connective tissue like tumors, or stromal tumors, or they call them sex cord stromal tumors. And if you remember, we had sex cord stromal tumors in the testicle, the Leydig cell tumors, the Sertoli cell tumors. Well, guess what? You can even have those rarely in the ovary too, but they can also be benign, usually benign, just like we said in the male. The so-called stromal tumors are generally mostly benign. I'm sure you could probably Google a couple of malignant ones, rare ones. But if you remember, some of these tumors, like the thecal tumors, which is part of a sex cord stroma, can still secrete estrogen, so they could be hyperestrogenic too, just like the granulosa cell tumors. In fact, granulosa cell tumor can be hyperestrogenic, and maybe it's been so hyperestrogenic, maybe there's been a cancer in the endometrium as well. Or they could be mostly fibrous and inactive or non-functional, In that case, they might be called a thecoma or a fibrothecoma. And even in the woman, you could have Sertoli and Leydig cells. And if you remember, the Leydig cells secrete androgens. So this is a woman that might have androgenic or male type features like hirsutism and so forth. Here is a granulosa cell tumor. And when you see a granulosa cell tumor, you may often see kind of circular nests with some cytoplasmic or cellular guy living there in the middle of these little cystic spaces. These are called Call-Exner bodies, if you wanted to know. Or they could just be basically looking a lot like granulosa cells like you see here. And you could suspect a high degree of estrogen. And even, well, you know, I think I'll have to tell you that most pathologists and most OB doctors will regard granulosa cell tumors as being potentially or downright malignant. I think you'd have to be very, very brave to call something a benign granulosa cell tumor. But let me ask you this. Do you think that the higher the estrogen level is on this tumor, the more differentiated it will be? In other words, do you think a obviously malignant granulosa cell tumor would probably, a highly malignant, highly undifferentiated granulosa cell tumor would produce less estrogen than something that looks like this, which is pretty well differentiated, looking a lot like normal granulosa cells? You remember, these are your granulosa cells B and C, but these D cells are called the thecal cells, and technically they're part of the stroma, but they still secrete estrogen. How do you know? Because they're nice and big as plump. Whereas the theca externa looks like fibroblasts. That's why a tumor of the theca externa primarily might be called a fibrothecoma, or more commonly, an ovarian fibroma. Okay, here's a thecoma. It looks white. You might call it a fibroma. And they actually could be called a fibrothecoma. And here's one that's a little bit more colorful. Okay, this, which I might ask you, which of these two tumors of the ovarian stroma is more likely to have a higher estrogen level in this woman's blood? And you would say, well, the one that doesn't look like it's fibrous tissue, perhaps this one. Okay, that would be a good understanding of pathology. Okay, we're going to take our break, okay? And when we come back, we're going to talk about diseases of pregnancy and diseases of placenta. So thanks for bearing with me through this first hour. I know there was a lot of material. I can promise you it'll be a little bit better, but still very, very pictorial in the second half as well. So let's hear some more rock and roll classic stuff from a couple of other guys, and we'll see you in about 10 minutes. I think it's kind of funny because we just heard Phil Collins say about 100 times, please take me home. But I'm asking you, get me the hell out of my home. Anyway, it has warmed up to 7 degrees, so I can't complain too much. And also, I can't complain too much because we're probably 2/3 done. The 2 topics that we have left are not nearly as big as the ovary, so let's get rolling. And then also, I have turned on the heater again, so you have already told me that the heater sound does not interfere with my lecture, so I'm glad to hear that as well. I guess there's a lot of things we could be thankful for if we just calm down a little bit. So let's continue with diseases of pregnancy now, and then we'll go into diseases of placenta. And as you might guess, diseases of late pregnancy overlap quite a bit with diseases of placenta. So start out with early pregnancy. There's basically 2 major concerns. One of them, of course, spontaneous abortion. The earlier you are in pregnancy, the more likely you are to have a spontaneous abortion. Incredibly, I mean, only if you look at the percentage of actually fertilized ovum that go to birth, it's like an amazingly low percentage, okay? And of course, in the first trimester of pregnancy also, you have to worry about an ectopic pregnancy where we have a blastocyst that did not implant in the uterus but is still in the tube, or perhaps even somewhere else in the abdomen, even more rarely. Spontaneous abortions range from 15 to 35% of all pregnancies, amazingly, depending on who you read. And of course, that whatever that number really is in truth, it's always the highest the closer you are to fertilization, okay? And I guess you could say there's 2 reasons. One of them is fetal causes. I'm not going to say it's the baby's fault. I'm not going to say it's the mother's fault, but I will just say you could divide them into causes. Most of the spontaneous abortions that are related to fetal causes are genetic. A general rule is, as you may know, if a baby is not able to survive because of what has happened in the development of that, it will not be born. It will be stillborn, or it will be even more likely spontaneously aborted. The maternal reasons or causes for spontaneous abortion are more. I mean, they're basically probably the number one thing are placental or uterine birth canal infections, okay, toxoplasmosis, big cause, mycoplasma, listeria. Okay, these are all placental / uterine type infections that will result in a spontaneous abortion. Of course, trauma, you can't exclude that either. So this is generally the overall differential diagnosis of spontaneous abortions. In the ectopic pregnancy, very often the word ectopic pregnancy is synonymous with tubal pregnancy, because that's where most of them, 90-something% are. But it could basically be an abdominal pregnancy as well. So tubal or ectopic pregnancies occur about 1% of the time in normal women. But women that have had previous inflammatory disease in the fallopian tubes, GC, chlamydia, okay, have a whopping 1/3 to 1/2 of a probability of an ectopic pregnancy. These are all in the first trimester, okay? So what are the presenting symptoms? Positive HCG, abdominal pain, first trimester, always, or most of the time. And they could be confirmed very, very easily and reliably on ultrasound. So how would you describe a woman that comes into the emergency room with ectopic pregnancy? Well, she's pregnant, and you can confirm that by the HCG. She's in the first trimester. She has abdominal pain, okay? And that's how they would present you with this case on a step question. I hate to keep bringing up the step, But in all honesty, I know that's your primary concern. I can't blame you. Okay, here is an ectopic pregnancy. You can see part of the uterus down here, perhaps the other fallopian tube. But this fallopian tube has either been ruptured or probably more likely dissected very nicely, because that looks like kind of a sharp edge over there. And this is a first trimester fetus. Okay, it looks like the head is about as big as the rest of the body. And of course, even something as nice as this could even be seen perhaps on the ultrasound as well. But you'll probably never get the opportunity to see a real specimen of a tubal pregnancy, a ruptured tubal pregnancy. And remember, these tubes can rupture, cause peritonitis, bleed, and they are more likely to rupture through the open fimbriated end rather than actually break through the muscular wall over here. But it's still possible. Okay? In the late pregnancy, if you notice, most of these anomalies, or most of the reasons or causes for late pregnancy problems, are related to the placenta. So if you just want to say placental diseases or anomalies are the chief cause of late pregnancy complications or diseases, you could say twin placentas also, placental infections, okay, which we also said was a very, very high reason for spontaneous abortions from the maternal causal point of view. And then this clinical condition known as toxemia of pregnancy. Some people may call it preeclampsia, which is a combination, a triad of symptoms. But when it occurs severely, perhaps with even neurological symptoms, perhaps even as horrific as things like convulsions, then you would no longer call it preeclampsia, you would call it eclampsia. And of course, intrauterine growth retardation. We talked about intrauterine spontaneous abortion, but anything short of that, growth retardation, would more likely occur in late pregnancy. Let's talk about the placenta first. If you've seen one, you're going to see one pretty soon, like here. That's about the most normal one you ever see. But could this thing have an accessory lobe or look lobulated rather than like a nice football? Yes. Could it actually be so lobulated that it looks like it's in two pieces, or what they call bipartite? Yes, I've seen that also. In fact, I have been sort of an expert on placental diseases, whether I liked it or not, because of the lawsuit I told you about. Could you have a circumvallate placenta, which is an interesting situation where the amniotic membranes kind of fold back upon themselves near their origin? Or could you have a placenta in which there is very little buffering decidua between the actual chorion or chorionic villi and the myometrium? In that case, you would suspect that probably would be a problem, infection, but mostly bleeding as well. Here's the world's most normal placenta. And if you always want to think of the placenta as being in three parts, you can. Only two of them are here, though. This is the chorion. This is the part in direct contact with the endometrium. Okay. Here are the amniotic membranes, nice and translucent. You should be able to read a little newspaper through them. If they're cloudy, that's probably a number one likelihood of them being cloudy would be an amnionitis. Okay. Here's a placenta. And quite frankly, when I looked at this thing yesterday, and I'm saying, why did I put this one in here? It actually looks pretty normal. Well, if you actually like to think of the umbilical cord as inserting approximately in the middle or near the middle of the chorionic mass, you can. But sometimes this placenta, the trivascular placenta, will insert sort of at the edge, or even where you can actually see the vessels apart from the placental mass, and that's called a velamentous insertion, and vela, I think, is like a veil. In other words, rather than having a nice round umbilical cord plugging into the chorion, you actually have this little stream, or you're starting to see the beginning of the stream of vessels. I wouldn't call this velamentous insertion, but it looks like it's kind of getting there, doesn't it? Here's a little lobe on the placenta. Very, very common, okay? Okay, if this lobe was very significantly large, or perhaps almost as large as the rest of the placenta, that would deserve the name a bipartite placenta. Here's a circumvallate placenta. These are all common things. I'm not saying you see them every day, but I've examined millions of placentas, and I've seen most of these things more than once. Do you see how this amnion membrane kind of becomes knotted or folded back or thickened, or what they call doubled back at the edge of the chorion? Well, that deserves the name circumvallate. Now, all these anomalies I'm talking about can have either no serious clinical effects or a very wide range of them depending on how severe they are. Here's something that's usually regarded as fairly severe. This is called a placenta accreta. Why is it? Why? Is it because this white stuff looks like concrete? No. It means that this white stuff, okay, part of the placenta would have very little uterine decidua, and they can be very, very difficult to remove. And if you can't remove it in one piece, it might be a grounds for infection. It also can be a common reason for endometritis or postpartum endometritis, okay? And they can also bleed as well. Think of it as being a placenta in which has no buffer zone between the chorionic villi and the myometrium because of absence of decidua, and that would be the source of the problem. Here's an ultrasound. Here's a baby. Here's a baby's head. Here's the uterus. And do you see how this placenta is low-lying? Well, let's say it lies low enough, okay, to actually obstruct the birth canal. That might be called a placenta previa or low-lying placenta. Another common thing that can also be detected pretty easily on ultrasound is something they call a placenta abruptio, or abruption of the placenta. And that means the placenta starts to separate from the uterus prematurely and bleeds, and you might see a hematoma. In this case, we just have a low-lying placenta, which is most of this mass over here, and here's the baby's head. That could be a problem too, because you know this baby will probably have to be taken out by C-section, and there's a zillion reasons for taking out babies by C-section, but this is probably one of the most legitimate ones, okay? And what about if you have twins? Okay, you got twins here. You got twins here and here and here and here. They could either share the same chorion in the same amnion, so that's monochorionic, monoamnionic, or they could share the same chorion, but two different water bags, or amnions, or they could have two chorions and two amnions, but the chorion is fused. So you can't really tell if it's one or two because it's fused, okay? Or they could have two complete, separate, independent chorions and amnions. And, okay, these are all the possibilities. And you might say, well, which are the ones are more common for fraternal twins or identical twins? Well, an identical twin, which of course is monozygotic because it comes from the same zygote, an identical twin will have one chorion. It might have two amnions, but it has one chorion, okay? And the chorion could be fused, so it looks like it's one chorion, but if you do the DNA studies on these babies, they're going to be completely different. So the point I want to make even though now we have so much more fancy ways of, in the laboratory, determining twins, if the twins are truly monochorionic, they're identical twins. What about diseases of later pregnancy, or in other words, after the second trimester? I will say after the midpoint or after 20 weeks. The most common, by far, abnormality is something called toxemia of pregnancy. It's a woman that comes in, she's hypertensive. She also has protein in her urine, so we know there's something wrong with those kidneys, right? And she's edematous, okay? Not only is she pregnant, large from being pregnant, but she's large from being generally edematous as well. These are the three classical triads or features of what they call pre-eclampsia. It's also called toxemia: hypertension, proteinuria, and edema. And you know, I have read so many theories as to what the abnormalities are or what the ultimate cause is for pre-eclampsia or toxemia, and they're most always related to placental ischemia. Now I know you're thinking, well, how could you have proteinuria related to placental ischemia? This whole triad, hypertension, proteinuria, edema, in one way or another, are generally, even the OB guys will tell you this, related to placental ischemia. Okay, now, if it's severe toxemia, where the woman also has central nervous system problems, the most feared of which are convulsions, then it's no longer pre-eclampsia, but it's downright full eclampsia. Very, very serious, okay? It has its own mortality and everything. And if you also remember that if this results in a difficult delivery, that's also one of the very, very big risk factors for DIC, to make the situation even more serious. What about if the baby is small? What about if by ultrasound they determine for the age of the pregnancy that the baby is smaller than it should be? What are the causes of intrauterine growth retardation? Well, we talked about the causes of spontaneous early abortion, but what if it's not early and it's not an abortion, but these babies are smaller than they should be? Well, once again, it could be fetal causes or maternal causes. And we said for spontaneous abortion, severe malformations and genetic incompatibilities resulting with basically incompatibility of like most of the trisomies, for example, are the fetal causes. But most of the causes are maternal causes. And of course, we talked about placental diseases, placental infections. A general rule of thumb, if it doesn't seem logical to you already, is that the placental size, which is mostly chorion, right? Because the chorionic mass is the majority of the placental weight. The placental size is related to the fetal size. So, if you take the two standard deviation limits of placental weights, we would weigh all the placentas from 350 to 700 grams is the range. If that's on the lower side, or even lower than 350, the fetus is likely to be lower than the normal American fetal birth weight of 7.5 pounds. So, if the baby is small, the placenta could very easily be small as well. The placenta can become infected because of two routes or two reasons. One of them is through the blood. Okay? It's called ascending. Okay? And the other one is called whoops, I think I made a little verbal goof over there. It could be ascending or hematogenous. If it's ascending, it usually means ascending from the mother, from the birth canal. So bacterial infections. Chorioamnionitis can be from the common bacteria, Listeria, Strep, Fusobacterium. These are all bacterial. So the ascending infections through the birth canal are usually bacterial. Well, could they be also herpes? Yeah, that's also a possibility as well. But most of them are bacterial. When you get the infection in the placenta, it usually involves, from the bloodstream, it usually involves the villi or the chorion. Okay, so chorioamnionitis is ascending, but when you see primarily changes in the actual chorionic villi, like for example, giant inclusions inside of the villi cells, then that's probably going to be hematologous. Now I'll make your life very, very simple, because I'm going to tell you that when the placenta is infected hematogenously, rather than ascending through the birth canal, bacterial, it's usually non-bacterial. So what's left? Viral. So what do we have? We have toxo, which is not a bacteria. We have rubella, which is a virus. We have a CMV, which is a virus. Then we have herpes. So that's why they call them torch infections, because the T stands for toxoplasmosis, okay, a unicellular parasite. Other would include everything else, but rubella, okay, German measles, CMV, cytomegalic inclusion disease, also in the herpes family. One of the characteristic features you would see on CMV, no matter what it's infecting, it can infect just about any part, lung, kidney, placenta. You see these basophilic inclusions within the cells. And this is a cell that's in the villus. Or herpes, also in the herpes family, but so is CMV. Okay, so much for placental infections. I hope I didn't confuse you because of my verbal typo, but they could be either through the birth canal, ascending, or bacterial, or through the blood, which is non-bacterial, and what they generally call torch infections, and involve the actual placental villi. I guess you could call that villitis, couldn't you? If it involved the chorion and the cloudiness of the amniotic membrane, you call that chorioamnionitis. And just to be complete, I actually looked at what they would call a phoenicitis. Phoenicitis is an infection of the umbilical cord. And when you see an infection of the umbilical cord, it's usually right near its insertion by the chorion, and most of the phoenicitis cases are associated with chorioamnionitis too. Okay, I think we're going to talk about tumors pretty soon, aren't we? Yeah. Make this easy for you again. Two kinds of placental tumors, benign and malignant, which is every kind of tumors. We've always divided into benign and malignant. Both of them are tumors of the trophoblast itself. Okay, if you remember, we have syntroblast, cytotrophoblast, and proliferations of these cells, which produce HCG, produce placental neoplasms. Benign placental neoplasms look like clusters of grapes, so that's why they're called hydatidiform moles. But the word mole itself means a benign placental tumor. And all of the malignant or invasive trophoblastic tumors can be called choriocarcinoma. Now, because both of these are proliferations of trophoblast, one is non-invasive, the mole, one of it is invasive, then you could say that both of them are associated with increased or persistent levels of HCG even after the baby is born. Okay, this is a part of a placenta. Here's the trophoblast. If you remember from histology, you have a syncytial trophoblast because the cells on the very surface often have fused cytoplasm, whereas the cells a little bit underneath is called the cytotrophoblast, which are more like the stem cells. But that's the tissue that proliferates in a placental neoplasm. If it doesn't invade, you could probably call it a mole. Sometimes they're called invasive moles, but I don't want to get into that. And if they invade, they could legitimately into the underlying stroma where you have blood vessel and connective tissue. Then they could legitimately call them choriocarcinoma. Moles are relatively rare in the United States for some reason. I'm sure there's a reason to it. But in Indonesia, there's as much as 1% rather than 1 in 1,000. They're 10 times more common in parts of Asia, especially Indonesia, than in the United States. Now, we said that the trophoblast is non-invasive in a mole, but you could have this borderline situation called an invasive mole, and it still would be called a mole, okay? If the mole involves the entire chorion complete, then it has a relatively small chance, but still 2% of developing an invasive, malignant, metastasizable, even post-birth choriocarcinoma. If the mole involves just a part of the placenta, what they call a partial mole, then there's no significant risk for choriocarcinoma. And why is the word mole often preceded by the word hydatidiform? Well, once again, I do believe, I don't know Greek, but I do believe that hydatid is a Greek word which basically was for grape-like clusters. So the villi are very, very swollen, and they look like little grapes. I'm going to show you a picture pretty soon. Yeah, here you go. Here they are grossly on the left. You might see a placenta in which the villi are swollen, look like these little grape-like clusters. And of course, microscopically, you would have the trophoblast lining the outside of these little grapes, and then you would have non-trophoblastic edematous connective tissue in the middle, almost like a papilla, isn't it? But it is the epithelial or trophoblastic component that is of most concern. So invasive trophoblast usually means choriocarcinoma. And that is the point I want to make by this big sign over here. The main thing, I'll read it word for word because I think you should understand it. Maybe you know it already. The main thing differentiating benign from malignant tumors of the placenta is whether the trophoblast is invasive or not. If it's invasive, like you see here, these are trophoblastic cells. They secrete HCG just like the benign trophoblastic cells. If it was a large tumor, you could have a massive amount of HCG. And you can see they are not delineated, they are not well defined, and they're very hemorrhagic, and they're not listed. Now, I think you'll agree also that these trophoblastic cells look malignant because some are bigger, some are darker, pleomorphism, hyperchromasia. But in this one here, I think there's going to be no doubt in your mind. Look at how big and dark, and we'll just say the word ugly, these trophoblastic cells are. So I think you could probably show this picture to any pathologist and he'll say choriocarcinoma. And he doesn't want to examine the HCG level or how invasive it is. These are cytologically malignant trophoblastic cells. We're done. I'm very happy. We didn't have to go the full 2 hours. We still get left a little early. And so you know what we're going to talk about in 2 days or 46 hours. We're going to talk about breast diseases. We're going to have a breast lab somewhere along the line. And then, I don't know how this is going to work out. I've allotted 11 sessions to genitourinary diseases. Maybe we'll be done in 10. But I think there's a reason for 11. Maybe I'll have another big lab at the end to make it 11. So this is what we'll be talking about all of this coming Thursday in 48 hours. Okay, do I have anything else I want to say? No, I don't want to show you my picture either, even though I'm not terribly cold right now. That's my mother, and that's my father when they got married. And let's close off the whole show with another classic. And by the way, this is really a great song coming up. I think it's by Phil Collins again. Here we go. Well, I usually say rock on buzzards, and of course I will. However, I think what I want to say even more is something that we just heard Phil Collins say about 10 times. And I'm very serious about this. Just think about it. Really, every day is another day in paradise. Even when you wake up in the morning, if it's only 1 degree, just remember one thing. You're still in paradise. Rock on, buzzards.